Good morning. I am Dr. Praveer. I am professor in the Department of Gastroenterology, SGPGI, Lucknow. And today we have with us a very eminent gastroenterologist, Dr. Shyam Varadarajulu. He is professor in Center of Interventional Endoscopy. This is in Orlando, Florida. Good morning, Dr. Shyam. So, when did you arrive in India?
Good morning, Praveer. I am here since Friday. I had a couple of family trips and here for the convention.
Okay. So, it's a really privilege to have you with us. Tell me something about your initial years of graduation and post-graduation.
So, I graduated 1993 MBBS from Madras Medical College. And then I went to England for a very short period of time to do some research. Those days, HIV was a big thing. I did a research for about a year in Scotland. And then I went to the US for my residency training. So I was in upstate New York at the University of Rochester doing 3 years of internal medicine residency. Then I did a gastroenterology fellowship at the University of Connecticut. That was for another 3 years. And then those days, advanced endoscopy was gradually getting popular. I spent a year doing ERCP with Peter Cotton in South Carolina. And then endoscopic ultrasound was very in its stages of infancy. And then I did another year of dedicated EUS fellowship with Robert Haas at South Carolina. And then afterwards, I was all done 16 years. Took my first job at the University of Alabama in Birmingham. Was there for about 9 to 10 years, and then transitioned to Orlando, Florida for the last 5 years.
A great journey. So, what made you feel interested for advanced endoscopy at that point of time?
So those days, most people in the United States would do a gastroenterology fellowship, and then you go into either practice or academic medicine. ERCP was more popular. Everybody was doing ERCP at the time, and then there were only about 5 centers in the United States that really had some sort of structured training for endoscopic ultrasound. It was very new. Nobody knew what the technology was. It was all gray and white images. It was all ultrasound. So a lot of people would think it's primarily radiology and it's got little to do with endoscopy and so on. But it was very clear at that point, if you want to have a career in advanced endoscopy, resections were not as popular. People just did polypectomy. So either you do ERCPs or you do EUS or you become a general gastroenterologist. And I was looking for the jobs in an academic program. EUS was the place to go. Everybody wanted to start because the oncologists and the pancreatic surgeons were demanding that the EUS must be available in their campuses and so on. So out of the 5 fellowships, I applied and then was fortunate enough to be selected for one.
So, what do you think? You do around more than 2,500 EUS per year, I guess, or more than that?
Yeah, we do about 4,500 now.
4,500.
Yeah.
So that's a huge number. So, what do you think out of these 4,500? How many are diagnostic EUS and how many are FNA? If we don't consider the FNA as diagnostic EUS, so how many diagnostic EUS do you do? What percentage of these 4,500?
So if I have to give you a Venn diagram, out of the 4,500, 1/3 are FNAs, 1,500. So 33% is FNA. Interventions will be about another 15%. That will encompass everything: drainages, fiducial placements, celiac plexus blocks, neurolysis, and everything. And about 35% will be just basic procedures: dilated bile duct, workup of pancreatitis, biliary colic, and so on.
Okay. So, do you think the advancement in MRCP and CT scan, the role of diagnostic EUS alone without an FNA is going to decrease further, or you think still it will hold promise?
That's a very important question. Depends on where you're practicing. So if you take the state of Florida, it's ironic that everybody who's old wants to come to Florida. That's the last part of your retirement because it's a very sunny place. So 1 to 2% of everybody in the United States after age 50 has a cyst on the pancreas. So in the US, the threshold for a CAT scan is very high. You just go for a headache, they will do a CAT scan. I mean, anything is a CAT scan. So a lot of incidental cysts are getting diagnosed. And when you see a cyst in the pancreas, unless proven otherwise, it's considered neoplastic. So people will look at a 3 millimeter cyst or a 3 centimeter cyst, and the first thing they will tell you is, well, the most accurate way of working up this cyst is going to be an endoscopic ultrasound. They get referred. So if you take my practice out of 4,500, 33% is only for cyst lesions.
Oh.
So my practice is very different from a practice that is possibly in New York City, where you could be having a much younger demographic profile. Their CAT scans and MRI might be just world class, and those patients may not have a cyst in the pancreas. But I agree with you. that in the initial stages, EUS was mainly used for wall layers, right? We were looking at 5 layers of the GI tract, and we were asking a lot of questions on luminal cancer staging and so on.
Yeah.
Evidence today tells us luminal cancer staging is out. Cross-sectional imaging is pretty damn good. The only time for luminal lesion evaluation is if you've got something like a spindle cell neoplasm, and if you get a tissue diagnosis, sure, EUS might be helpful. But I agree with you, all the luminal cancer staging indications are significantly going down, and even for small lesions, EMR, if you can lift it, you just take it out. You don't need an endoscopic ultrasound to define it further and so on. So FNAs is probably the way for diagnostic lesions, and cross-sectional imaging will take over cancer staging, and the role of EUS will continue to decline.
So what about therapeutic EUS? You think therapeutic EUS has plateaued as of now, or you think there are many indications which may come forward in EUS, especially say vascular interventions or other procedures, EUS guided therapeutic procedures?
So all the randomized trials have clearly showed us that for the most common indication, pancreatic fluid collections, EUS is the way to go. Compared to surgery, compared to percutaneous techniques, it's a very mature field. So now we have all the evidence to prove that this is the way to go. And I have a feeling, unless you have a fluid collection that cannot be accessed, something like a lower abdomen or a pelvis where you will require a ward or a percutaneous drain, everything is going to be managed by endoscopy. So that field will continue to evolve. We will have newer stents and newer avenues to manage them by endoscopic techniques. So that will grow. Biliary drainage will be a platform that I think, at least for extra hepatic bile duct obstruction, probably in 5 to 7 years, it's my prediction that ERCP will continue to decline and EUS might be used something like biliary obstruction from pancreatic cancer. The intrahepatic indication is going to be a real estate shared between radiology and endoscopic ultrasound, and to some extent ERCP, because we can't get to all those things. Vascular interventions is an evolving field. I think there's gastric varices, there's only so many of them. A lot of those referrals come from hepatologists. For hepatologists who are very tuned to interventional endoscopy, they are prone to send these patients. I do not personally think there is enough data to prove that EUS guided approach is superior to just blind glue injection using endoscopy. I think we can put some coils, we can do a few things fancifully, but I don't think there's much data on it, and that's a small, finite population. My personal take is for advanced interventions, EUS guided tumor ablation is going to be a significant role. I think there's going to be neuroendocrine tumors, palliation of pain in pancreatic cancer, celiac ganglia lesions, pancreatic cyst neoplasms with high risk features that will require ablation. This is an evolving field. Right now we have EUS guided RFA. They are not the best equipments. We don't know how much thermal power to apply, how long to apply. We don't know what is the end point. We don't know how to follow up. But this is a field in its infancy. I have a feeling if I have a crystal ball and if I have to look into the future, I think tumor ablation is the way it's going to be. Not today, but 5 to 10 years down the line. That's where it is.
Okay. So there are many young gastroenterologists who want to pursue with each and every therapeutic procedures like ERCP, EUS, and now we have third space procedures like POEM procedure, EST procedures. So what's your advice to the young gastroenterologist who should be taking up these advanced therapeutic procedures? What qualities in one gastroenterologist should be there to pursue with these procedures?
So you are a hardcore academic doctor. I've followed your career for many years. You're very disciplined. Your approach is primarily dedicated to pancreatic biliary diseases. You focus on EUS, ERCPs. You continue to build your practice. With some disappointment, this is not pertaining to a particular geography throughout the world that you will see us. Those days when we train, we focused. You pick up a EUS, you pick up a ERCP, or you do a pancreatic biliary work. Or people have a tendency to work upon resections, or they will work on third space endoscopy, or resections plus third space endoscopy. I personally feel if you want to be excellent in what you want to do, you want to be recognized as a center of excellence, and you want to be known as the person with expertise in that area, you have to focus. I do not think you can be a king of all trades. You can be a jack of all trades. If you want to master EUS, ERCPs, I think you have to stay focused too. If you want to focus on third space endoscopy and resections, you need to focus on it. If you want to do everything, I do not think you're going to be good in everything. I really don't think so. And my concern, Praveer, to be honest with you, in our profession, for some reason, people feel that they must know all the procedures, so that if you're going for a conference or for a meeting, they think that they can display their skills and they are more, marketable. They've got multiple tricks down their sleeve. I think it's a very short-sighted nature. If you want to be recognized globally as the leader in your field, classic example, Peter Cotton or a Nip Sohindra, they were focused primarily for pancreatic biliary work, ERCPs, and they became global leaders. And if you want to take resections, if you take Naohisa Yahagi, or if you want to take Yutaka Saito, or you want to take Michael Burke, primary area of focus is resections. Then you can reach wherever you want to reach. You will have the best outcomes for your patients. You can do the best quality research. You will be able to focus on the literature, know the gaps in the literature and where you are practicing, and you can publish and be recognized as a leader both locally, nationally, and internationally. But if you want to go, and if you want to learn everything, and if you want to do everything, unfortunately, you're setting yourself up for a disappointment.
So I think last few words, some words of advice for young gastroenterologists, which you would like to put forward.
If you're an endoscopist, and if you want to pursue a career in advanced endoscopy, at least in the United States, I will tell all trainees, spend a few years in an academic institution. It's very important. And the reason you work in an academic institution is because you get instilled in you the discipline of a certain quality of work, yes, certain quality of ethic, and dedication to a particular area. And after you go through what you call 3 to 5 years of working in a confined space, or even if you're going to a corporate hospital, you work under the mentorship of an experienced person in an area. After 5 years, you can go do what you want. But during the time, it will give you an opportunity when you're working in a focused area to identify the area that you really like to focus your career on. I think that's important. If you're going to graduate and you're just going to go straight away to your facility where you're expected to do a lot of things and you're not very well prepared, you are not going to do very well in the long run. I think it's very important to be under the mentorship of a person in a focused area, dedicating the first 5 years to a specific region of interest. And then afterwards, I think you'll have a very, very good career because you've invested in your future. If you do not invest in your future by focusing, focus is the key word. If you do not invest in your future by focusing, then I think later down the line, you will always be searching for something that you don't.
True. Thank you, Dr. Shyam. It was a privilege, and you are always so energetic and enthusiastic. So nice meeting you.
Yeah, it's such a pleasure being here. Thank you so much.